So guys, now we'll be starting with the chapter 238 of the Harrison's Principles of Internal Medicine. Okay, so this is also the last chapter of the section 1, which was about the introduction to cardiovascular disorders. So before starting with the chapter, please stay motivated to study because medicine is a long subject. बहुत सारे lectures होंगे, बहुत सारे videos हैं, लेकिन I'll make sure कि आप लोग एक बार वीडियो देखने के बाद काफ़ी ज़्यादा कंफर्टेबल हो जाएं, के बाद आप खुद से स्टडी कर सकें, बुक से रीड आउट कर सकें. ओके, सो दिस चैप्टर विच वी आर स्टार्टिंग इज़ वेरी PSM काइंड ऑफ अ चैप्टर, तो हम लोग इसे बहुत जल्दी कवर कर सकते हैं. Okay, so without further delay, let's get started with the chapter. So this is the epidemiology of the cardiovascular diseases. Introduction. Cardiovascular diseases are the leading global cause of death. Approx 32% deaths are due to these cardiovascular diseases. There has been a gradual shift from infectious diseases to non-communicable diseases in the secular trends. Okay, this affects both high-income countries and lower middle-income countries, both. Okay, so this was about the introduction. Now comes the epidemiologic transition. So the factors can be categorized into 5. First being the pestilence and famines. CVD percentage is less than 10%, and predominant CVD types are rheumatic heart disease, infection-related cardiomyopathies. Next are the receding pandemics. 10 to 35% of the disease are because of these, and hypertension, CHD, stroke, rheumatic valvular disease are the examples. Next up are the degenerative or man-made problems, due to which 35 to 65% of CVDs are there, like CHD, ischemic and hemorrhagic stroke, etc. Next up are the delayed degenerative reasons. 40 to 50% of the disease are because of these. Okay, so CHD, stroke, heart failure can be because of them. And inactivity and obesity contributes to approximately 38% of the share. CHD, stroke, peripheral vascular diseases are the examples which are caused because of these factors. Okay, so now the patterns in the epidemiologic transition. High-income countries, in the high-income countries, CVD death rate fell by 50 to 60% over 60 years. US model urbanization increased CVD till 1965, then declined with prevention therapy. Okay, now in fifth phase, decline has slowed. Obesity and diabetes factors are rising. Okay, there are some regional variations as well. Like in the North America and Northwestern Europe, rapid declines have been seen after peaks. In Central or Southern Europe, gradual rise and fall has been seen. In Japan, high stroke and low CHD due to diet have been seen in Mediterranean regions. Lowest CVD rates in Europe are in the Mediterranean regions. Okay, in the lower middle income countries, CHD and stroke are increasing. 85% of global CVD burden lies on the low and middle income countries. Urban versus rural gradient is there for cardiovascular disease prevalence. And there are varying stages across regions, like in China, stroke is 3 times as compared to CHD. In Vietnam and Cambodia, they are emerging from stage 1. Middle East or North Africa are in stage 3. Latin America, stage 2 to 4. Heterogeneity is there. And in Eastern Europe or Central Asia, peak of stage 3 is there because there is high working age mortality. Okay. In India, Western transition is there. CHD is dominant, coronary heart disease, and there is persistent rheumatic heart disease also. Okay, and sub-Saharan Africa mainly is stage 1. Okay, so this is very like factual data. It's nothing to understand about it. So बस एक बार आप देख सकते हो. बाकी this chapter is not at all important. बस ये ट्रेंड्स बता रहा है आपको कि ग्लोबली क्या चल रहा है अभी. So global CVD trends, 2017 GVD study updates set the improved data collection and modeling. CVD is 32% of global deaths, and CHD is 16%, and stroke is 11% of all the deaths. Stroke is more impactful in low and middle income countries, okay, because they have almost 3 times the high income countries burden. Between 1990 to 2017, CVD deaths have increased by 49%, but age adjusted death rate has reduced to 30.4%. What's the problem? Aging and population growth both are contributing to the total CVD deaths. Projected rise in CVD patients despite falling mortality rates is projected. Okay. So now coming to risk factors for CVD, the first being tobacco. There are approximately 1.4 billion users, 7.1 million deaths per year, out of which 2.6 million are from CBD. So, out of 7.1 million people who die of tobacco chewing, uh, the reason for 2.6 million of them is cardiovascular disease. Smoking rates falling globally, but the user numbers are increasing because of population growth. Okay, 5,75,000 approximately deaths from second-hand smoking were there in 2017. Next up is diet. As income increased, the intake of animal or saturated fat, simple carbs, and plant-based are increased, and plant-based food decreased. Obviously, like जो लोग ज़्यादा के पास पैसा है वो ज़्यादा बटर वगैरह अफोर्ड करेंगे, ज़्यादा मीट एंड ऑल प्रोडक्ट्स पे जाएंगे, एंड प्लांट बेस्ड फूड कम होगा, सो दैट विल ऑल्सो कॉन्ट्रीब्यूट टू दी डेवलपमेंट ऑफ डिजीज. Fat less than 20% calories in rural China or India, and but more than 30% of the total calorie intake is from fat in the US. Okay. Now the physical inactivity, this is linked to industrialization and urbanization because लोगों के पास time नहीं है तो workout कर नहीं पा रहे. 1.3 million deaths per year are due to inactivity. 27.5% global inactivity prevalence was there since 2001. Okay, high inactivity rates are in urban areas, for example, China. Mortality highest in the Middle East, Central and Eastern Europe. Next up, metabolic and genetic risk factors are also there. So, metabolic risk factors, the global burden of the disease 2017 study was to provide insight into the trends in four key metabolic risk factors. First was the lipid levels, because cholesterol contributes to approximately 42% of the ischemic heart disease deaths, 9% of stroke deaths, and 4.3 million deaths per year. Global cholesterol levels decreased from 1980s to 2008. In men, it decreased by 0.08 millimole per liter per decade, and in women by 0.07 millimole per liter per decade. The sharpest decline was seen in Australasia, North America, Western Europe, and the rise has been seen in East Asia and the Pacific regions. Okay, next up is the lipoprotein A. It's the emergent independent CVD risk factor. Okay, it is elevated in approximately 20% of the people globally. Higher levels in people of African descent, and PCSK9 inhibitors may reduce LPA. The researchers are ongoing. The next contributing factor may be hypertension. The risk starts at systolic blood pressure more than 110 to 115 millimeter per Hg. Okay, prevalence 1990 to 2015 was there. They increased from 73k to 81k per 1 lakh people. And systolic blood pressure more than 140 millimeter Hg increased from 17k to 20.5k per 1 lakh people. Systolic blood pressure more than 140 mm of Hg, only 25% of them are hypertensive, and but this causes 73% of the BP related deaths. This cardiovascular disease problem is causing 73% of the BP related deaths. CVD attributable to hypertension, 55% of stroke deaths, 55% of CHD deaths, total 8 or approximately 8.25 million deaths were attributed to this factor in 2017. It's all data, okay. Low middle income countries death rates are increasing. High income countries the rates are decreasing. Urbanization drives BP up. Detection remains low in low middle income countries. For example, urban India hypertension prevalence is approximately 33.8%. Next, hemorrhages, strokes. They are high in Asia due to undiagnosed hypertension. The mean global systolic blood pressure is decreasing in men by zero point 0.8 and in women by 1 mmHg per decade. Okay, and a very much important contributing factor to cardiovascular diseases is obesity. 2015 estimates 603 million adults and 108 million children were obese. Global adult obesity prevalence is approximately 12%, in children it's 5%. CVD leading cause of obesity related deaths 2.7 million of the 4 million. BMI trends from 1975 to 2014 were like women, it increased from 22.1 to 24.4 kg per meter square, and in men it increased from 21.7 to 24.2 kg per meter square. Like globally, everyone's getting fat. Okay. Next, obesity prevalence in women it increased from 6.4% to 14.9%, and men increased from 3.2% to 10.8%. The highest rates in men were in US, Latin America, Australasia, Western Europe, and in women were Africa, Middle East, Latin America, and the US. The lowest rates were in Southeast Asia, East, Central, West Africa. Obesity often coexists with undernutrition in low middle income countries, and other than this, adolescents are also increasingly at risk. Next up is the diabetes mellitus. There is a rise due to obesity plus inactivity. Okay, so the prevalence has increased dramatically from 1990 to 2017. Men, there has been approximately 129.7% rise in the cases, and in women 120.9% rise. The current global estimates are like 476 million people are living with diabetes type 2 dominant. The projection is like 693 million people will be living with diabetes by 2045, and 50% remain undiagnosed, and 80% in low middle income countries remain undiagnosed. Highest prevalence or incidence is in the Middle East or North Africa, 8.7%. Okay, 400 per 1 lakh people. The lowest prevalence is in the East Asia and Pacific, they are like 5.8%, 249 per 1 lakh people. The future growth concentrated in South Asia, Sub-Saharan Africa, maybe. Okay, next up are the genetic risk factors. These focus on germline genetic variants tied to CVD, like CSD or stroke. There can be risk factors, associated risk factors like hypertension, lipids. Okay, there can be hundred to thousands of the variants. Okay, they can be combined into polygenic risk scores. Small explanatory power, अभी इनकी power इतनी मतलब develop नहीं हुई है because it's undergoing research. Okay, so most data from European ancestry is there, but global efforts are expanding. CHIP, clonal hematopoiesis of indeterminate potential. There are some somatic mutation in the hematopoietic cells. Okay, so due to these, there are approximately 2 times greater risk of coronary heart disease. Okay, no hematologic abnormalities is required other than this. So this will itself complete the disease progression. Okay. So this was a very basic and data PSM kind of chapter. Finally, the summary and strategies. The key takeaways from the chapter are like CVD burden is rising in low middle income countries despite the high income countries have shown some progress. Okay, these are driven by metabolic risk and undetected disease and underlying diseases. So, what are the population strategies? The complementary strategies are like population-wide prevention. We can promote anti-smoking. We can promote healthy diet. We can promote physical activity campaigns. There can be some targeted interventions like screening of the high-risk group from hypertension, hyperlipidemia, and we can explore some low-cost prevention like polypill, aspirin, statin, antihypertensive drugs. And acute and secondary prevention, like once the disease had occurred, we have to prioritize mortality morbidity data collection, early screening of the disease. We have to invest in scalable and affordable interventions. Regarding the global perspectives, they are like high income countries must support global research and development because they have already shown some progress and they also have money, so they should support. Okay, they have to they should transfer low cost solutions to the low middle income countries. कि आपने भाई कैसे अचीव किया? If you ask America कि आपने ये decline कैसे अचीव किया, so they should pass their solutions to us. Okay, and finally epidemiologic transition model, they should be made which guide some global cardiovascular disease strategy. So we have to work all together as a world, as a community, so as to reduce the cases and the complications of the disease. Okay, so this was all about this chapter 238, which was based on epidemiology of the cardiovascular diseases. Okay, so this completes the chapter and it also completes the section 1, which was about the introduction. In the next video we'll be starting with the section 2, which is about the diagnosis of the cardiovascular disorders, which is medicine proper, which is going to start now. Okay, so okay, keep studying, like, share, subscribe. Thanks for watching.